Welcome to today's webinar, Resident Series, Back to Basics in Full Denture Technology, Part 2. It is being presented by Dennis Urban, CDT. And with that, I get to turn it over to Adam Dreyfus, Corporate Account Manager, University, Government, and Institutions. Take it away, Adam.
Good morning. Thank you so much, Jessica, for the warm introductions. And good morning to everybody, the Greater New York resident class of 2021 to 2022. Please know we do not take this lightly, your partnership, and we really do value everything that you do provide. As I've mentioned before, we are here for you today, tomorrow, and the future, and please know that we mean that wholeheartedly. And with that, we are investing today with your education. So Dennis Urban, please take it away.
Okay, thank you, Adam. Thank you, Jessica. We have such a great team here at DSG and NDX. So happy to work with you guys. But happy to be here this morning also, and welcome everybody. I know it's early. We're going to do part 2 of Back to Basics in Full Denture Technology. And before we get started, I'm going to do a couple of minute, 2-3 minute review on what we talked about last time. And then we'll get into more of the occlusion and setups and processing and things like that. So, and just keep in mind, this is a Back to Basics program, and we will be doing other programs more advanced as the year goes on. So, so let's get started with part 1 review. What we talked about in part 1, oops, let me do this here. Here we go. Part 1 review, we started with, communication, and communication is key between us at the laboratory and you planning these cases. So we really need to have all our ducks in a row when we're planning these types of cases, not only with information from the patient, information on the background of the patient, and information from you also. So we depend on your clinical knowledge and training, the assessment of the patient, the appropriate treatment plan, and detailed information on the prescription form. So that's really important. So if you can do write down a detailed information on the prescription form, that's going to help us at the bench. We want to feel like the patient's with us at the bench there. So we want all that information with us at the bench here. So digital photography helps. And of course, the correct materials, the high quality materials that we utilize in making dentures. And from us, the certified dental technicians at the laboratory will come across with any technical expertise we have on procedures and materials and give you the appropriate feedback on impressions, bites, shades, etc. So it's really important that we catch the error in the beginning of the case rather than going throughout the whole case, finishing it and realizing something was wrong. So we have a pretty in-depth quality control procedure in the laboratory to pick up on these things. Just in case you might have missed it in the operatory, we get it at the laboratory. We'll give you our feedback on impressions and everything else. So, and impressions are probably the number one thing that we call the doctors on. We don't want to proceed if the impression is not good. So, and we go through case planning with you, the dentist, and if it's an implant case, of course, the oral surgeon also. So, and we depend on digital photography and the advice and we give you advice on proper case planning with the proper materials. And, not only digital photography, but we need all the information we can on the patient, especially when we're doing full mouth reconstruction and full upper, full lower cases. And sometimes we even get little short videos of how the patient's going into different excursions with their occlusion. So that helps us also. So everything helps when we're making these cases because we have such a large space to fill on a full upper and full lower denture. We have this over 40 millimeters of intraocclusal space. We want to get it right. We have to think of all the aspects of making that denture, including occlusion, aesthetics, and patient satisfaction. And another thing that we covered was the impression taking techniques on full dentures. And this included giving us all the information we need with borders, anatomical landmarks, hamular notches, retromolar pads, and a proper border molding. It's really important that we get the proper border molding on these cases. And so what I recommended, and there's a couple of different ways you could do this. I recommended, putting adhesive on a custom tray and using a monophase or heavy body material, and then putting that in the mouth, have the patient move their cheek around, try to capture all the musculature and muscles of the mouth. And then we'll take that out of the mouth and come over with a medium body material. And if you're doing a reline or anything, I suggest maybe a light body material, but a traditional impression, I like a medium body material because it doesn't run as quickly. And then we talked about bite registrations. This is important. I spent a lot of time on bite registrations and occlusal records. So we talked about getting the right occlusal records, make sure that patient is in the upright position We want to make sure we get that contoured occlusal rim to you so you have less trimming to do in the operatory. And we want to make sure there's no interference with the wax or base plate when the patient bites down. And more importantly, whether it be a digital denture or a traditional denture, we have to mark the midline, the high lip line, and the cuspid lines into the wax. That's really important. I'm going to show you a little later on about how we do a denture setup when we didn't get any information from the doctor. And it can be challenging sometimes. So we get that information from you at the operatory level, and we have that on a occlusal record. It helps us in the laboratory. And also we talked about articulation. There's many different articulators on the market. When we're doing full mouth reconstruction, we try to utilize either a semi-adjustable articulator or a full adjustable articulator. And it's important, even if you're articulating these casts in the office, we still get a lot of doctors who are articulating their own casts and send it to us at the laboratory. But when you're mounting these cases, you really want to make sure the occlusal plane is marked to the occlusal plane of the articulator, and it's parallel to the workbench or the desktop. And the center of the model is identical to that of the articulator. So, and then we have to align the incisal point to the incisal indicator on the articulator. And as you can see on this picture here, I put a rubber band on the incisal pin, and there's a little slot in that incisal pin that goes around the incisal pin and then the posterior part of the articulator. And that's your campus plane or occlusal plane. And we try to follow that when we're setting up these models on the articulator, because it's going to help us when we're setting denture teeth. We don't want something that's going to be angled or angled down or forward or to the side. It's going to probably end up in a reverse smile type of setup. So we want to make sure we get that information correctly when we're mounting these cases. So usually we'll mount the lower first, then we mount that upper to the occlusal plane, as you can see here. Nice and even, beautiful articulation and a nice articulator. And then we're ready to set our denture teeth. So that's pretty much a quick review of what we did last time. So we're going to get into part 2 of Back to Basics in Denture Technology. And no matter what course I give, whether it be an advanced course or a medium course of something intermittent in your as far as the information goes, I always try to go back to the basics. It's really important that we look at the basics, because without the basics and following those basic rules, you're not going to have a successful case. So let's just touch on what we talked about last time. We talked about the clinical protocol for removables. And this is much different for when we talk about digital dentures. And we'll have those digital denture courses coming up throughout the year here. And we can cut those visits down to about 3 visits, with the clinical protocol for the removal on digital dentures. So, of course, we talked about preliminary impression the first visit, making a custom tray for your final impression for the second visit, occlusal records on your third visit. And we're going to start today with the tooth setup and wax try-in. And then, of course, the 5th visit is a final insertion. And you can eliminate a visit if a functional impression is taken inside that occlusal rim base plate and a bi-registration is taken on the second visit. So you can cut that 5-visit patient protocol down to 4 visits. So again, when we do these denture try-ins, we want to check for occlusion, phonetics, and shade, and make sure the patient is happy. Because you want to, we're going to go to process. If everything looks good and you say go ahead and process the case, that's there's no point of no return. We're going to process this, so we want to make sure the aesthetics are pleasing to the patient. Patient's not happy, nobody's happy. So really, keep that in mind. So here we go. It's time to do a few setups. We're going to go through setup techniques here. It's nice to know the techniques behind when you get a denture in your hand at the operatory. What went behind that? What was behind that denture in making that denture? So let's talk about doing setups. First, we're going to talk about using the correct teeth. It's really important to that we look at this aspect of removable technology. There's a lot of denture teeth out there on the market, and you want to make sure we use the correct ones. So we want a tooth that's going to be the same size as natural teeth, something with high wear resistance, lingual anatomy for better phonetics. And the reason why I put that down is because many new denture patients, their tongue tends to slide off the lingual of the teeth, and they tend to lisp for a while. And it takes a while for them to get used to that denture. So I always recommend, I know we do a lot of cases with smooth palates, but a natural feeling rugae in the palate and good lingual anatomy on the anterior teeth is great, because the patient's it feels natural to the patient. And sometimes we'll go as far as duplicating what the rugae the patient has in their mouth already and we take an impression of that, and I make a wax pattern out of that, and it's the exact same form of the patient had in their natural tissue, and we transfer it over to the denture. So it really works out well. And then with bleach shades, a lot of patients like a lighter shades now. The bleach shades, they want to look like a lot younger than than they are with these cases. So we give them bleach shades, a white shade. Sometimes they look a little too white, so we want to make sure we get that a shade that's going to be aesthetic. But the ultimate thing is, is it pleasing to the patient? So and then we're talking about Vita 3D shades. That's going to be something that 3D shades we utilize a lot with crown and bridge. So if we're doing combination cases, say we have a 6-unit bridge on the anterior and it's a 3D shade, we can match that with the posterior teeth when we're making a partial. So, and then also we utilize the classic shades also. I put Vita down here because that's pretty much the most popular shade guide that we use in the laboratory. So here you see the lingual anatomy on these denture teeth here, and the natural rugae on this denture that I made, and it's really natural looking, and it feels great in the mouth. So we don't want something that's going to be acrylic too high on the lingual of the teeth. So we bring that down to right to where the cervical is, and then we put that rugae in there, and it's nice and comfortable for the patient, and it's nice and contoured. I've seen dentures over the years where the palate is really thick on the anterior region, and the patient just cannot get comfortable with it. And we want to make sure it's a nice, smooth transition from the lingual of the anterior teeth all the way to the acrylic. So denture tooth criteria, we want to use a functional inclination of about 20 to 33 degrees. And the reason why I say this is because, we want that patient to tear and chew their food easily. If we use a 0-degree tooth, it's almost like chewing like a cow. They're sliding back and forth, and they're not really able to tear their food correctly. So we want something with better tearing and chewing capabilities. And, look for a denture tooth, and that's what we utilize in the lab, with a wider occlusal plane, especially for partial dentures. How many times have you seen a partial denture where it's a narrow occlusal plane and they just don't look natural? And for the wider occlusal plane on denture teeth, the patient is going to tear and chew their food more effectively. And then there's different emergence profiles. There's so many different types of teeth to choose from, and different emergence profiles for whatever the facial features are of the patient. So we really want to follow facial features, because pretty much facial form equals anterior tooth form. And we're going to get into that in a few minutes. But how do we select anterior teeth? Well, one of the ways I select anterior teeth, I have an upper model. I look at my upper model, and if you look at that shape of that upper model, it's usually the shape of the centrals. And that's what I've been following all these years. So all these years picking out denture teeth, I look at this shape and I say, is it a square tapering? Is it an ovoid? Is it a square mouth? And I look at it, then I go to the tooth cabinet and I pick out the appropriate teeth. Then many times I'll go to the tooth guide, the mold guide, and that'll give me an idea of what posterior teeth go along with these anterior teeth. So we have to determine the mold, like I mentioned, by the shape of the arch, or if the patient has an existing denture and they're happy with that mold, we can match that mold. So you send a study model to us of the patient's existing denture, and we can follow that. And we want to look at the width of the 6 anteriors, and what we'll do is take a millimeter ruler and measure cuspid to cuspid. And how many millimeters that we see there, we go to the tooth chart, and it'll tell us what anterior tooth to place in that occlusal rim and that setup. So a lot of different tools to use. It's a big challenge for a lot of people when they're picking out denture teeth. And I have some tips and tricks over the years. Some of them I just mentioned to you that have helped me over the years. And many times we'll get a mold that the doctor picks out in the office, and that eliminates a lot of time for us in the laboratory. But many times the doctor will have a living mold guide in the office, and the patient and the doctor will pick out that appropriate tooth. I mentioned earlier, tooth form equal facial form. So this gentleman on the left, this is an old photo, but I like to use this as a reference point. Square face, square tooth, square tapering tooth. And this woman has sort of an ovoid type face, and you see an ovoid type of central that we're going to be utilizing. Again, this is another photo from another tooth chart, manufacturer's chart, and you can see it follows along with facial form equals anterior tooth form or central tooth, the centrals on these on dentures. And we have a lot of natural anatomical landmarks too to follow, so on the maxillary anterior teeth, the tips of the canines are equal to the width of the nose usually, and the width of the centrals are usually equal to the width of the philtrum. So we have a lot of these anatomical landmarks, unless the patient has some kind of cosmetic surgery or a nose job or something like that, then this rule pretty much works well, with following this rule. And we look at facial form, and this is why I love to get a picture of the patient when I'm setting my denture teeth. We can get a digital photo of the patient, and we can look at the patient. We sort of break up the face here, as you can see. The pupil line is equal to the occlusal plane, and then we have the smile line and the midline, and then we have our cuspid line. So we take all that into consideration when we're setting our denture teeth. Really important. So let's talk about setting denture teeth now. And we want to replicate nature. We want to have the patient look like they're not wearing a denture. So this is what we try to achieve in the laboratory. And we'll even have some doctors set the anterior teeth into the occlusal rim and send it back to us and tell us that, this is how the patient likes the arrangement of these anterior teeth. Just set the posterior teeth and keep the anterior teeth the way they are. So many times we get a lot of cases back like that when they're setting the anterior teeth in the operatory. We want a harmonious and aesthetic effect when we're setting these teeth. Let's talk about setting up the anteriors. Aesthetics and phonetics are key. And when you talk about setting anteriors, the anteriors are positioned individually and parallel to the pupil line. And you can see how much time it takes. It takes a lot of time to set up denture teeth, and I'm sure all of you know that. And when we get into digital denture technology, you'll see how easy it is to set these denture teeth. They usually come in focus or on the screen in a full arch setup. But the important thing is you really have to know the science behind what you're doing, even what's on digital dentures. Because you're going to be moving some anterior teeth or posterior teeth, you really have to know how to arrange those. Even though the software helps you. So the anteriors are positioned individually, parallel to the pupil line, and the lower incisal edges are parallel to the upper incisal edges, as you can see here. So I usually set my denture teeth. I set my upper anteriors first, and then my lower anteriors. And then I look at the anatomical landmarks on the models. So if you look at this lower model here, I drew a line down the crest of the ridge, because what happens with this the ridge here, when I'm setting my posterior teeth on the lower, I don't want to deviate from that ridge. I want the central fossa of that tooth to be on the central right this crest of the ridge on the lower. If I deviate from that or go away from that rule, we'll probably have an unstable denture. Patient's going to have sore spots. You're going to have more bone atrophy on the lower. That's why we've seen so much bone atrophy over the years, because ill-fitting lower dentures and improper occlusion. So it's really important to keep that into consideration. So we mark the crest of the ridge. Now, just to show you, you see the retromolar pads. I actually drew a line through and bisected the retromolar pads, because when we set our second molar, usually we're coming about 2/3 of the height of the retromolar pad. And the anatomical landmarks on the upper model, as you can see here, I'm circling that papilla, and I put a dot on that papilla because on an average, we're coming about 8 to 10 millimeters out from the papilla when we're setting our denture teeth. So it's real important. Then we have, the havereal notches in the post-dam area, fovea palatina, and we look at all these different aspects of an upper and lower model, and everything comes into play. And we have to realize that, all these anatomical landmarks have to be used correctly in fabricating a full upper and full lower denture. So I mentioned earlier about a case that we received in the laboratory. We didn't get any information at all on the occlusal rim. We didn't get the cuspid lines. We didn't get the midline, smile line. So what am I doing here? I'm looking at the average intraocclusal space here, and it's about 40 millimeters. And so we're going to start setting our denture teeth. And on an average, when you're setting anterior teeth on an upper, you're setting in about 22 millimeters from the periphery. And on a lower, going about 18 millimeters from the periphery. So the first thing I do, I take a little sticky wax on my base plate. I spread it on the base plate so the base plate wax sticks to it. And I'm ready to set my anterior teeth. Okay, good. All right, so if you look at this picture here, we have a minimum ridge resorption here on the upper photo. And something like this, I would probably go about 6 to 8 millimeters from the papilla when I'm setting the anterior denture teeth. And teaching over the years and going to laboratories and doing seminars, I see a lot of technicians setting denture teeth, even doctors setting denture teeth on the ridge. And what happens if you set teeth on the ridge on this lower photo here? You have maximum ridge resorption. So what's going to happen? The patient's going to look sunken in. So on this particular case, I would probably come, this photo here, I would probably come about 8 to 10 millimeters out from the papilla. So sometimes a little bit more, if we have a lot of resorption. So the first thing I'll do, I'll place my upper central, and I want to make sure the upper central points towards the buccal fold. And then I'll place on an Alma gauge to verify that 8 millimeters. So if you can see on the lower right here, the lower photo here, on the right, I have a pin that's going to go into the papilla on the faceplate. And you can see on this Alma gauge, which is a great tool in the laboratory and the operatory, I came out about 8 millimeters from the papilla. And I do this with occlusal rims also. When I have occlusal rims, I want to contour that occlusal rim as close as I can to where the patient's natural teeth were. And so it eliminates a lot of work for you in the operatory by cutting back wax and contouring. And I try to do the same thing, when I'm doing my setup. So I place my centrals at the correct inclination. And you can see how tedious this is. This takes time, especially when you're doing full mouth, reconstruction or full upper and full lower denture. So I place those centrals at the correct inclination. And then I place my laterals at the correct inclination. If I want a bolder look, I'll keep them straight up and down. If I want a softer arrangement, I'll twist those laterals. So at this point, though, I want to check my occlusal plate. And so I place my cuspids at the correct inclination, and I verify the 6 anteriors on the occlusal plate. And what I mean by verify is those centrals are going to touch the plate. The laterals are going to be about 1 millimeter off the plate, occlusal plate, and then my cuspids are going to be touching the plate. So I have contact on the centrals and the cuspids, but not the laterals. So it's really important and there's a reason why I do this. It helps when we're going into working and balancing. So there's no interference when we're setting our denture teeth on the upper and lower. And at this point, I can check for symmetrical arrangements. I can do this after the setup is done also, but I want to check. I usually check at this point for symmetrical arrangement of the anteriors. And at this point, we can twist and turn and it can be altered. So one of the things that we're doing now on the digital side, I like to do comparisons because you're going to be hearing a lot about digital dentures, is that we print a try-in on the digital side. And when we print the try-in, you can't move these teeth because it's one big block it's a try-in that's printed in one piece. So a lot of doctors try to move teeth around and they can't because it's a printed monolithic try-in. But at least with the analog way, you can, if you need to move teeth in the mouth, you heat up your spatula and you can arrange the teeth in whatever way the patient wants. So as a review, the central and canine are on the occlusal plate and that lateral is off the plate, as you can see here. And sometimes we have to adjust the base plate material allow for a maximum room. I see a lot of people just grinding their teeth down to nothing. And, these teeth can be expensive. And the more you grind a denture tooth, the more you lose the shade integrity, the more you lose bonding strength. So I would rather grind away some of the base plate than grind away the teeth. But believe me, I've seen in my trainings over the years that a lot of people who are setting denture teeth, they just grind that teeth down to nothing. So be careful of that if you are setting your own denture teeth. So we're going to set the lower centrals, allowing 1 millimeter of vertical and horizontal overlap. And we got to keep in mind in the inclination, so keep in mind that inclination too when you're setting these teeth. And I like that 1 millimeter vertical and horizontal overlap because that gives the patient a little bit of freeway space. There are some cases where I set in physiological centric occlusion, they call it, where I have tight contact on the anterior teeth also, and the posterior teeth. And in the posterior teeth, we have like 30 points of contact. That's a lot of contact, especially for a new denture patient, so I like to give them a little bit freeway space, check my working and balancing, there's clearance there so the patient doesn't trip that denture and doesn't interfere with anything. So when I look from the sagittal view, the incisal third of the central should be in line with the buccal fold. And then I place my laterals and cuspids following the guideline on the lower, following the guidelines of the upper anteriors, as you can see here. So at this point, I'm ready to set my posterior teeth. So we're going to get to that in a few minutes. But I don't know if you heard me speaking before about a functional impression with and a functional bite registration, and that eliminates one visit. What happens if you do that? Because what you're doing is actually taking an impression inside that base plate and then taking a bite registration. We're going to pour a model and mount that, but If we set denture teeth on these base plates, it's going to be loose because when to pull out the impression material, it's going to be loose. So we have to make a new base plate. But if the doctor gave us the information, if you gave us the information we needed with the cuspid lines, the midline, the smile line, we want to preserve that. So what I do is I make a putty matrix. So this was a functional impression. You can see how loose it's fitting now. And, I'm going to make a new base plate when I set my denture teeth. But you can see I have all the information I need here. I have the cuspid line, the midline, and I have my high lip line. So I'll go back and forth. I'll have this base plate and I use it as a reference tool. But right now I'm going to make a new base plate so it fits tighter. Because I want that patient to feel like it's the final denture in the mouth when we're doing a try-in. And that's why we utilize light cured base plates or a base plate that's going to fit really well, almost like the finished denture. And at times we'll get asked to do a process base plate, which is the actual material that's going to be used in the final denture. And we'll process a base plate out of this denture base material, and then we set our denture teeth on there. And when we go to a finish, we just process our denture teeth onto the that process base. So what I'm doing here, I'm following the guidelines. What the doctor gave us on the occlusal rim. I set my upper essentials. My laterals are off the plate. You can see that's even off the putty index here, at 1 millimeter. And I set my cuspids. And I follow the guidelines of what I just talked about. I follow the guidelines of the upper when I'm setting my lower anterior teeth. So how do we select posterior teeth? Well, we have to look at the type of occlusal scheme that we're looking at so that the patient can tolerate. And that's why I think anywhere from, I'm going to go so far as to say a 15 millimeter cuspal inclination all the way to a 33-degree cuspal inclination. So my average is about 23 degrees that I utilize. I find that most patients who have full upper and full lower dentures can tolerate that, and they can eat very, very effectively with it and chew their food and function. Because denture may look good, but you want it to function also. So we'll look at the occlusal schemes, the type of degree of tooth that we're looking at, and the teeth that are out there, we have semi-anatomical, anatomical, there's 0-degree teeth, and there's posterior teeth for lingualized occlusion. I don't use 0-degree teeth that much. And the only time I probably use 0-degree teeth is on a class 3 bite, so I don't want any interference. But, and lingualized occlusion, most of the time I'll use lingualized occlusion when I'm setting my teeth on implant cases, whether it be a hybrid case or an attachment case. And I'll talk about that in a minute. So for a class 1 bite, normal bite, I'm going to use my traditional posteriors anywhere from 15 degrees to 33-degree cuspal inclination. Class 2 bite, I might go a little bit small, a little bit lower, maybe 15, 20 degrees. And when I talk about a class 3 bite, I'm going to use a 0-degree tooth when I'm setting my posterior teeth. And here's a picture of some of the different anatomical teeth that are on the market here. You have monoplane. Again, I'm not a big fan of monoplane, and I see a lot of people using monoplane when I'm doing my courses and teaching. And a lot of times they're using it because it's the easy way out. It's easy to set monoplane teeth. I want something that's going to be interdigitate correctly and give the patient the ability to chew. So, and then we have our lingual contact. Years ago, we used to use a higher degree of cuspal inclination on the upper and a flatter tooth on the lower when we talked about lingualized occlusion. Because what we were trying to achieve was that lingual cusp going into the central fossa of the lower teeth. And that's going to relieve any off-axis stress on a ridge or on the implant. So different degrees of teeth. Typically, the smaller the ridge, the smaller the bony ridge, the less degree of tooth that you'll utilize. And the greater the ridge, so the larger the ridge on the upper or lower is the greater degree of cuspal inclination. So at this point, we want to select the correct mold. And we showed this picture before. When I'm first teaching this to people who are starting to set up denture teeth or learning about dentures, I draw a line 2/3 of the hydroretro mold pad because that's going to give me an idea of where to set that second molar. And we align the occlusal surfaces towards the center of the cranium. And as you look at this picture here, those lines are going from buccal to lingual, which is your curve of Wilson. And the only time I don't have my curve of Wilson is when I'm setting lingualized occlusion. So as you can see on the right-hand side, it's more of a even plane. And what we'll do, I have a curve of Spee, but I won't have a curve of Wilson. And because I want that lingual cusp to go directly into the central fossa of the lower when I'm setting my lingualized occlusion teeth. The actual inclination of the posteriors are to the center of the cranium. We talked a little bit about Facebook transfers the last time I gave this presentation, and I love a Facebook transfer when we're doing full mouth reconstruction or full upper and full lower dentures, because it gives me an idea of how the cranial access relationship is of the patient, and I transfer that over to the articulator. So I'd love to have that information. And what we're doing here, same thing. It's the axial inclination, which is the curve of Spee on the lower. And then we're setting our upper denture teeth to follow that curve of Spee and give us that curve of Wilson also. So a little review, setting posterior teeth. We want to make sure the central fossa of the teeth are on a lower ridge because it might be unstable if we don't stay on that ridge. And we want to check our vertical inclination of the posterior teeth, check our curve of Spee, and check our curve of Wilson. Again, as a review, from buccal to lingual, there's your curve of Wilson, and from anterior to posterior, your curve of Spee. It's all a natural curve in the mouth that we try to mimic when we're doing with denture setups. So now we're ready to set up posterior teeth. This is one of the methods I use. I'm going to show you another method in a minute. So what I'll do first is set my upper bicuspid, and then I'll set my lower bicuspid and interdigitate with each other, and I'll get my occlusal plate. And you can see on the lower here, this is a clear occlusal plate that I have here. I have the lingual and buccal cusp touching that occlusal plate on the bicuspids. And I'll set my upper teeth first, and then my lower teeth. And when I get to the first molar, I want the mesial cusp of that first molar touching the plate and the distal cusp to be off the plate. And on a lower photo here, you can see that I have the second molar not touching the plate at all. And what is this doing? It's giving me a good curve of Spee. I do it manually like I do here, or you can utilize a curved template, which I'm going to show in a minute. So once I set these posterior teeth, I just set the lower to align with the upper teeth. I check my height of contour and my vertical inclination, and then I'm ready to wax up the teeth. So, and there's something called an OMP template that I utilize also, and it aligns the buccal ridges of the molars and premolars. And I use this tool all the time. It's called the Colbeck OMT template, and I utilize this also when I'm making the occlusal rims. So this is a great tool to have. So I have my upper and lower teeth set here, and everything looks good. I'm going to check, go into excursions, check for that working and balancing, and make sure there's no interference. I look from the lingual aspect of it. I want to make sure there's good tight contact, and then we're ready to wax up our denture. And this is the final wax up of the setup that I just did. As you can see, I try to keep the anatomical look to it. I want the patient to feel like they have their final denture in their mouth when they're trying this in. So if we wax it like this, we have a good setup, good tight fitting base plate, we're going to be in good shape. So we're going to be, excellent shape when we're sending these denture teeth, and the patient's going to be impressed with it. So you want that harmonious transition from the anteriors to the posteriors, you can see here. It's a completed individual anterior setup, and then our posteriors have, that harmonious inclination towards the anterior also. So really important. So we did a nice setup there. The other technique I utilize is a template technique. I was asked a number of years ago, it was a large laboratory down in North Carolina, and they said, we want to try to increase production in the laboratory, but we want to be quality minded. Do you have a technique? So I was lecturing at the time for Jensen Dental, and I was lecturing using a different type of articulator, and they had a template technique. And so I'm going to show this template technique now. So this is the Artex articulator. And keep in mind what I just showed you in that previous setup that I did with no information. We're going to follow those guidelines right now also. So we have upper and lower base plates already made. I cut a little hole out where the papilla is just to show you where I'm going to put that Alma gauge, and we're going to set it about 8 to 10 millimeters from the papilla. So 40 millimeters of interocclusal space here. And the first thing I'll do, I'll set my upper 6 anteriors like I did previously. And then, I check the arrangement on the occlusal plate, and like we did before, I'll set my lower anteriors, and usually it's about 18 millimeters from the periphery to the incisal edge on the posteriors on the lower. So I have a nice upper and lower anterior setup rather. And then I'm ready to put my, set my teeth here. So I'm going to set all my lower teeth. So this went totally against my guidelines all the years I've set up denture teeth. So I was a little skeptical. So I have this template that I'm using, and I think this is a 20-degree template. So all I did, I took the upper model off the magnetic articulator, I put the magnetic template on, and all I had to do was set these posterior teeth against the template. Worked really well. So I set up, and it helps achieve curves of Spee, curves of Wilson, and it's different size templates from 0 to 35 millimeters. So it's cuspal degrees. So it's a great tool. And so I set this up, and I set all my posterior teeth around against this template. You can see how nice this looks? I got my curve of Wilson, my curve of Spee. Look how nice the contact is on a lingual. And all I had to do at this point was set my upper denture teeth against these lower teeth. Look how nice it is. We're right on the ridge, 2/3 of the height of the retromolar pad. Anterior, posterior setup looks great. And then we set our upper posteriors against the lowers. And look how nice it came out. So it was an easy way. I probably saved maybe about 15, 20 minutes on a setup, so we saved some time. Not that, my goal is not to save time, it's just to give you a good setup here, but this is another way that you can utilize articulating systems with templates. And there's the final wax up. This is an actual case. So the final wax up for try-in. I did a characterized wax up, came out beautiful, and nice anatomical tooth we used, and setup turned out great. So there's a close-up of the wax try-in I do. You can see I put these little anatomical veins in there. I put little eminences and carvings, and it looks really nice. And this also saves me time later on when I finish the case. So I utilize different waxes, on the market for colors. It is. I have aesthetic colored wax, because many times I get a call from the doctor, or it's on the RX asking me to match the patient's gingiva, even in the denture try-in, and I can do that. Of course, we charge more for that, but it's you can do that. And of course, with all the different aesthetic colored waxes out there, we can mimic that. And then we take a digital photo of that try-in, and we actually mimic that on the final denture base staining when we finish the denture base. I'll show you a picture of that in a minute. So we shape that denture base in the wax, precise shaping. It eliminates a lot of our finishing later on. And which one do you prefer, the one on the left or the one on the right? So I think I would take the one on the right there. So, but again, beautiful wax up, nice setup. Techniques that I've used for the years has been proven successful. And I'd just like to give you the laboratory aspect of this also. So now we're ready for the final visit here. Fifth visit is final insertion. We're going to check for fit, form, and function, check for pressure spots, and we want to equilibrate that occlusion. Many times, occlusion doesn't have to be equilibrated if it's done correctly in a laboratory. But sometimes, the bite could be off a little bit. Might be processing error, and sometimes you have to equilibrate that occlusion. So there's a lot of different processing methods out there. I like the injection method; it works great. But still, the number one processing method, even compared to digital dentures, is conventional investing and packing or press packing. And this is where you take the acrylic and you put it in a flask, you squeeze it down 2 or 3 times, and you process it from anywhere from 2 to 8 hours in a curing unit. But when looking at denture bases, we want something with a natural look, a low shrinkage factor, something with a variety of gingival shades. And the really important thing is a great bond to denture teeth. I've seen some inferior materials out there over the years. You go through all this trouble making a great denture, and it doesn't bond to the denture base, and teeth pop out of the patient's denture. So we want something with impact resistance, but you can't have impact resistance with flexural strength. So it's really important, especially when implant cases going over a bar or attachment cases. And something with good finishing and polishing properties, color, fit, and stability. And these are some dentures I made with this different shades of acrylic. This is a high impact acrylic, as you can see here, and with various shades here to match the patient's natural gingiva. And then you can also, if you want to really match the patient's gingiva exact, we can utilize specific denture-based stains. And as you can see, this is a stained denture, and we added some redness and a little lightness on the cervical area, and to make it a little more natural looking. And this is a real dramatic one. This is an full upper and full lower denture with physio-dense denture teeth, 33-degree cuspal inclination, and a special denture-based stain that we utilize on the periphery and also around the teeth. So this is a beautiful denture, really nice. And this is in the patient's mouth, but we didn't get the patient smiling, so we couldn't, with the lip higher, so we didn't get a picture of the actual what the gingiva looks like. But you can see how natural this face looks in the mouth, how beautiful. And there's a lower denture, came out really nice. So Artistry through denture technology, that's what we try to do in the laboratory, but we also want to make sure that we utilize the advancements in denture technology also. So we're going to be talking about those advancements later on as we go through these courses, and you're going to be pretty amazed at where we've come so far on this evolving technology on the digital aspect of denture technology. But also, the ultimate goal is patient satisfaction. We want to have the patient functional and have nice aesthetics and have the patient's lifestyle raised to the next level. But with that, I want to thank everybody for joining us today. If you have any questions, please go ahead and ask. And thanks for joining us, and we look forward to seeing you next time.